evening, everyone. This is Ankana, the assigned moderator from IJCP Group. I welcome all the delegates across the country in today's session. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. As we all know that today is World Hepatitis Day, so it's very obvious that we are going to have the session on this event only. Hence, without any further delay, I'm just taking this opportunity to welcome today's speaker, Doctor, none other than our very well-known Dr. Soma Shekhar Rao, sir. Sir is going to cover the topic that is, do we need to treat all viral hepatitis? Sir is the senior consultant gastroenterologist, hepatologist, and advanced therapeutic endoscopist at Yashoda Hospital, High-Tech City, Hyderabad. Now, sir, I would like to hand over the session to you. You can proceed with your discussion. Over to you.
Thank you very much, ma'am. So today's my topic is do we need to treat all viral hepatitis? That's the question always we have. I thought we will have to discuss about this and go ahead. I will start my presentation, and if there is any question, maybe I think you can put it in your inbox. I will answer during or after the session. So today we are going to discuss about topics are acute viral hepatitis, chronic viral hepatitis, and special situations. So coming to acute viral hepatitis, most important acute hepatitis A. So hepatitis A most of the time is a self-limited, and treatment always consists of supportive treatment, and medications that might cause liver damage or are metabolized by liver should be used with caution. Full clinical and biochemical recovery is observed within 3 months in 85% of patients, and complete recovery is observed by 6 months in nearly all patients. Important thing is patients with fulminant hepatic failure, which happens in less than 1% of cases, they require aggressive supportive therapy and should be transferred to a center capable of performing liver transplantation. And how do you diagnose acute liver failure? Altered mental status in a patient with acute viral hepatitis and INR going more than 1.5 suspect acute liver failure, and these are the patients who needs to be treated immediately. So hepatitis E is one more acute viral hepatitis. Most important for patients, the management is supportive only, and as the disease appears to be mild and self-limited in immune-competent patients. Patients with acute HEV infection who develop fulminant hepatic failure may require liver transplantation, and most of them are pregnant females who develop fulminant hepatic failure in hepatitis E. So chronic HEV can occur almost exclusively in immunocompromised patients, and management of this chronic infection involves reduction of immunosuppressive therapy and or antiviral therapy with ribavirin for 12 weeks. This is very important to understand, and ribavirin should not be used in pregnant women and it is a potential teratogen. Remember these things, these are very important. And let us go to hepatitis C. This is a case-based discussion where we will be covering how to evaluate and how to treat hepatitis C case. So this is a 56-year-old female who was incidentally detected to have anti-HCV, which was reactive, and she was planned for a hysterectomy. And she was referred to us for clearance for surgery and further management. So now we will understand how do we evaluate this patient. So any patient who has come to you with anti-HCV reactive, we need to do these tests immediately. CBC, liver function test, prothrombin time and INR, and renal function test. HCV RNA quantitative or viral load, and basic ultrasound abdomen. These are very important. And in this patient, these are the reports. Hemoglobin was 11.1, total count was 4,100, platelets 1.3 lakhs. Bilirubin 1.2, SGOT is 36, SGBT is 27. Albumin was 3.4, INR was 1.32. RFT was normal, and viral load showed 22,430 international units per ml. Simply, if you see, this patient definitely needs treatment. Anti-HCV positive and viral load is positive. But why we should do all other things like CBC, LFT and all is to know the liver status. Ultrasound grossly says it is grade 1 fatty liver and bulky uterus. But see, the little abnormality what I find here is low platelets, little elevated INR, and SGOT is more than SGBT, which is not normal. So I won't say there is fang cirrhosis, but I would definitely suspect some amount of fibrosis already. She's a 56-year-old female. Most probably she must have acquired this infection 15, 20 or 25 years ago. So some amount of fibrosis is what I am suspecting, which we are not able to confirm with ultrasound. So here I went ahead and did a fibroscan. So her cap is 283 and median KPI is 14.1. Anything more than 8, I would suggest it is fibrosis. Up to 18, it is fibrosis. This is F2 fibrosis according to me. So fibroscan, how do we read? There are two values here, CAP score and the KPA. So CAP score 238, less than 238 is normal, 238 to 260 is S1 steatosis, and 260 to 290 S2 steatosis, and higher than 290 it is S3, which is again saying the amount of fat respectively. And grading of fibrosis, better not to be confused with all these things. Anything up to 7 is normal, anything from 8 and above is fibrosis, and anything above 18 is considered as F4 fibrosis or cirrhosis. I think this should be a simple thing to remember for everybody. So here in this patient, definitely there is a fibrosis, and treatment option definitely, according to the guidelines, we have two combination medications which are approved for treatment: combination of glacipravir and pibradesivir, which is taken after with food for a duration of 8 weeks, and a combination of sofosbuvir valproatasvir for a duration of 12 weeks. Sof and Valpa combination is widely available in India. So this particular patient was started on sofosbuvir and valproatasvir for a period of 12 weeks. That is around 3 months. How do we follow them up? This patient was reviewed after 12 weeks of treatment. Only thing I would ask all of you to remember is whenever we are giving a combination of sofosbuvir and valproatasvir, please avoid giving them PPIs and warn them against taking PPIs. They should not be on PPIs when we are giving them on sofosbuvir and valproatasvir. So after 12 weeks, her hemoglobin 12.1, total count is 6,200, platelets are 1.5 lakh, INR has come down from 1.32 to 1.2, and even the fibroscan shows median KPA of 6.6, and HCV RNA is less than detectable limit. Just with 12 weeks treatment, we could see reversal of fibrosis, which is ideally, yes, very good response for the patient. HCV RNA less than detectable limit after completion of treatment. This is called end of treatment response, but we will have to follow up this patient again after 12 weeks. So you stop the treatment at 12 weeks and follow them up after 12 weeks again. So if the HCV RNA, it should be done again. And if it is less than detectable limit, that is what we call as sustained virological response or SVR. And whenever you achieve SVR in a patient with hepatitis C, it is equal to cure. So at this point of time, what I want you to understand is any hepatitis C with a viral load detectable, even if it is 100, you have to treat them with antivirals for 12 weeks. Do their viral load again after completion, that is called end of treatment response. After completion, wait for 12 more weeks and then do a viral load again. That is called sustained virological response. And the viral load, if it is undetectable at that point of time, we call it as cure to hepatitis C. But only thing what I would suggest is if the patient has fibrosis or early cirrhosis during the initial surveillance, all these patients are at risk for HCC, hepatocellular carcinoma. So this patient should be followed up regularly for surveillance for HCC. So the primary aim was they referred to us for fitness for surgery. She is obviously fit for surgery, no risk of transmission. She can be taken up for surgery. It is very simple. All patients with hepatitis C, if the viral load is detectable, you have to treat them. Any patient initial evaluation, if you see fibrosis or cirrhosis, you have to follow up them even after complete cure for development of HCC. This is important. Let us go to the next few cases are only about hepatitis B. So hepatitis B is not that simple like hepatitis C. So I would like to discuss different scenarios So here is a patient who is a 36-year-old male who was incidentally detected to have HBsAg. So how do we evaluate him? When do we treat him? What about his family members? So evaluation, I will talk. We don't treat all patients with HBsAg positivity. So we need to understand whom to treat, whom to wait and watch. So how do we manage their family members? How do we prevent infection? These are all important. So first, let me answer the last question. All family members should be tested for HBsAg, and if they are negative, all of them should be vaccinated with 3 doses of hepatitis B. Family members vaccination can be accelerated. If you give the first dose today, second dose will be after 1 month, and third dose after 2 months. So 0, 1, and 2 is an accepted accelerated vaccination dose for hepatitis B in high risk individuals. So, answering the second question, when do we treat him? Before knowing this, I would like all of you to look at this one slide, which is very, very important in deciding the treatment of hepatitis B positive patients, HBsAg positive patients. So previously, there was a terminology called immune tolerant phase, immune reactive phase, inactive carrier phase, and a chronic HBAG negative chronic hepatitis phase. So now the terminology for hepatitis B has changed completely. All your patients should be tested for hepatitis E antigen and antibody. So if someone is HBAG positive, they are again divided into chronic infection where there is virus but it is not causing any damage to the liver, and chronic hepatitis where there is virus and it is causing damage to the liver. These are the patients who needs to be treated. Similarly, hepatitis B E antigen negative also, there is chronic infection where there is virus and it is not causing any damage to the liver, you don't treat them. And chronic hepatitis where there is viral load and causing damage to the liver. So these are the patients whom we need to treat. So we categorize them into four categories, and two of them needs treatment, two of them doesn't require treatment, but they need to be followed up closely. So whenever you see a patient, you have to divide them into these one of these four categories and decide whether they require treatment or not. So this slide is very, very important in determining the treatment. And once you see them, you need all the investigations on your left side. So you need HBeAg and anti-HBe. You need a liver function test to look at ALT. You need a HBV DNA quantitative, and you need an ultrasound in all your patients. That's what we are going to discuss. Initial evaluation. So this patient HBsAg is positive, HBeAg is positive, anti-HBe is negative, and when you are talking about LFT, SGOT is 68, SGPT is 112, and viral load is 1,10,000. Ultrasound abdomen is normal. So question is, do we treat him? Now again, I think we will go back to our slide, which category he is falling into. So HBeAg is positive, right? HBeAg is positive, and the SGALT is elevated. So this patient comes into this category, HBeAg positive chronic hepatitis, where we need to treat them definitely. You have to treat this patient because his enzymes are elevated. Simple. SGPT is elevated. You need to treat this patient. And what are the treatment options we have? Remember, long-term administration of a potent nucleoside analog with high barrier to resistance is the treatment choice regardless of severity of liver disease. And what are the regimens we have? We have entecavir, tenofovir, and tenofovir alfenamide as monotherapies. Other medications like lamivudine, edifovir, telviudine are not recommended in the treatment of chronic hepatitis B. Please remember this. We have only entecavir, tenofovir, and tenofovir alfenamide for treatment of hepatitis B. So you start them on any of those three medications. How do we follow? Initial follow-up would be at least in first 3 months. What are we looking for? We are looking for normalization of SGPT. We are looking for at least 1 log reduction in the viral load. These are the things what we look in the first 3 months. So SGPT and SGOT have normalized, and viral load from 1 lakh 10,000, it has come down to 6,000. Definitely, it has, our targets are achieved here. So subsequent follow-up should be once in 3 to 6 months, and every visit we need to do a liver function test, alpha fetoprotein, HBeAg, HBV DNA viral load, and ultrasound. So viral load is to see how our treatment is, how the patient is responding to our treatment. LFT obviously again similarly, or SGOT, SGPT. All these patients are at risk for HCC, so we need to keep screening them with alpha fetoprotein and ultrasound abdomen once in 6 months. HBeAg is what we need to know, because once HBeAg was positive at the time of initiation of treatment. So this answers why we need to do. Is there any endpoint of treatment? Yes. In this patient, when HBeAg is positive and anti-HB is negative, your target of treatment, endpoint of treatment would be normalization of LFT, viral load less than detectable limit, HBeAg seroconversion. HBeAg positive should become HBeAg negative, and anti-HBe should become positive. These are the three targets what you are looking at in patients with HBeAg positivity. So once you achieve these three targets, you wait for 6 months. You have to continue the virus antivirals for 6 more months, and then uh, you can stop your nucleoside and your medications. And even after stopping, remember you have to monitor them closely once in 6 months for the viral load. There can be, and in non-cirrhotic patients only, we will be able to stop this treatment. And we are talking about HBeAg positive patients. Next, we will talk about HBeAg negative. Second scenario, this patient CBC was normal, SGOT is 20, SGPT is 24, HBeAg is positive, anti-HB is negative, and viral load is 22 lakhs 10,000. Ultrasound is normal, fibroscan is normal. So, do we treat this patient? So, again, I would go to the first slide. I will show you the same thing again. This patient has HBsAg positive and HBeAg is also positive. Viral load is very, very high. ALT, SGOT, SGPT is normal. So, you are seeing a normal SGOT and SGPT, and this is a patient who has HBeAg positive chronic infection. You need not treat them because the liver disease is very minimal or none. But you need to follow up these patients, because these patients can go into chronic hepatitis phase. So just follow up for once in 6 months. You don't treat them. Third scenario, third case. This is a 46-year-old male who had easy fatigability and tiredness, underwent a comprehensive health check, found to have HbSAg positive. LFT total bilirubin 1.3, SGOT 79, SGPT 64, hemoglobin 12, WBC 5200, platelets are 1.1 lakhs. Ultrasound says normal liver with mild splenomegaly. Again, there is a lot of abnormalities here if you observe closely. Grossly, if you see, you feel everything is normal. But again, I would say SGOT is more than SGPT, which is a problem. Platelets are 1.1 lakhs, which is again a problem. And you are seeing normal liver, but splenomegaly on ultrasound. This again says there is some amount of fibrosis or early cirrhosis in this patient. This is very important. INR is 1.3, HBeAg is negative, viral load is 33,000, fibroscan shows median KPI 18.1. That itself says there is early cirrhosis. UJ endoscopy shows early esophageal varices. So in patients with cirrhosis and for HbSAg positive, you don't need to wait. You just don't need to wait for viral load also. If the patient is cirrhotic HbSAg positive, straight away start them on antivirals. And there is no end point for antivirals in these patients who already have cirrhosis. So once you start them on treatment, you have to continue lifelong. And this was the initial oh, it is reverse actually. KPI is 3, I mean cap is 341 and KPI is 15.1. we already talked. We start them on either of these, entecavir, tenofovir, or tenofovir alafenamide. Initial follow-up in first 3 months. Further follow-up should be 3 to 6 months, and all these tests should be repeated once in 6 months. So after 1.5 year of follow-up, this patient's reports are as follows. See, his platelets have improved from 1.1 lakh to 1.8 lakhs. SGOT and SGPT normalized, and reversal of ratio is seen. SGOT is more than OT. INR has come down to 1.12. Ultrasound has become normal. Fibroscan shows KPA of 6.6 again. Remember this, after treatment for with antivirals, there have been lot of studies which say within 5 years, if there is early cirrhosis or fibrosis, it can be reversible in hepatitis B. So detecting them and starting on antiviral is very, very important. All these patients who require antivirals lifelong, there is always a possibility of resistance even to the highly potent medications available. So we need to do viral load once in 6 months in these patients. So in this patient, definitely there is no endpoint of treatment because it is a cirrhotic patient. Only endpoint we are talking in non-cirrhotic patients. Special situations, I would like to talk about hepatitis B in pregnant females. So this is a 28-year primi gravida, 28-week primi gravida, aged about 26 years. She was found to have HBsAg positive. And how do we evaluate this patient, and how do we prevent transmission of hepatitis B virus to the baby? This is very, very important. This is the most important route of transmission of hepatitis B in our country even today. So all pregnant females or childbearing females, childbearing age, females of childbearing age should be tested for hepatitis B. All pregnant females should be tested for hepatitis B. And if we know there is hepatitis B in the mother, it is then only we will be able to prevent the transmission of hepatitis B from mother to child. So how do we evaluate? Like any other patient, we do all these blood tests: CBC, LFT, HbAg, viral load, and ultrasound abdomen. So what are the recommendations in pregnancy? Screening for HbSAg in the first trimester of pregnancy is strongly recommended. In a woman of childbearing age without advanced fibrosis who plans a pregnancy in the near future, it may be prudent to delay therapy until the child is born. But pregnant women with chronic hepatitis B and advanced fibrosis or cirrhosis, therapy with tenofovir is recommended. Tenofovir is safe in pregnancy. In pregnant women already on nucleoside analog therapy, tenofovir should be discontinued, while entecavir or other nucleic acid should be, tenofovir should be continued, and all other things should be switched to tenofovir. In all pregnant women with high viral load, so here in the guidelines they say more than 2 lakh international units, or HbSAg levels more than 4 lakh international units per ml, antiviral prophylaxis with tenofovir should be started at week of 24 to 28 weeks of gestation and should be continued up to 12 weeks after delivery. And breastfeeding is not contraindicated in HbSAg positive untreated women or on tenofovir based treatment or on prophylaxis. So remember one thing, breastfeeding is not contraindicated. So next question here is, so remember only one point, all women in their third trimester, if the viral load is more than 2 lakhs, you have to start them on antivirals, and antiviral which is approved in pregnancy is only tenofovir 300 mg once daily. And how do we prevent the transmission? Antivirals in last trimester, and Hep B vaccination and hepatitis B immunoglobulin to the baby immediately within 24 hours after the birth. So management protocol in HbSAg positive pregnant carrier. Remember this, HbSAg positive. Look at viral load and predominantly in the last trimester. Viral load more than 2 lakhs, even if the LFT is normal, all those things doesn't. Higher risk for maternal to child transmission. So start on tenofovir and not elbubedin, lamivudin. It is only tenofovir at 28 to 32 weeks. If the viral load is less than 2 lakhs, there is lower risk of maternal to child transmission. Just administer HBIG, I mean immunoglobulin, and first dose of hepatitis B vaccination to the infant within 12 hours of delivery. So this is the algorithm. Remember this. And hepatitis B vaccination protocol, all of us should know. Most important, unvaccinated patient pre-exposure prophylaxis. We should be taking hepatitis B vaccine 0, 1, and 6. It applies to everybody. There is no age limit. Children who are born after 2011, as a part of universal immunization program, they are being given this vaccine during birth only. Perinatal exposure, that means child born to mother with hepatitis B. Hepatitis B immunoglobulin 0.5 ml immediately after birth, and hepatitis B vaccination should be started within 12 hours. So, percutaneous or transmucosal contamination, hepatitis B immunoglobulin 0.06 ml per kg plus hepatitis B vaccination within a week. And if there is a sexual contact, hepatitis B immunoglobulin 0.06 ml per kg within 14 days with hepatitis B vaccination should be done. So most of all of us are in our high risk groups. We may have needle pricks in a vaccinated individual. If we are not vaccinated, all of us should get vaccinated, number one. And even after vaccination, if there is an accidental needle prick, these are the precautions to be taken. Anti-HBs titers is very important and should be assessed. I would suggest don't wait for a needle prick. All of you should get your anti-HBs titers once in at least 3 to 5 years. If your anti-HBs titers are more than 100, even if you have a needle prick, there is no intervention required. Please look at this. If your anti-HBs titers are 10 to 100, one booster dose should be given. And if your anti-HBs titers are less than 10, you should be considered unvaccinated. Hepatitis B immunoglobulin 0.6 ml per kg within 72 hours, along with 3 doses of hepatitis B vaccination should be given within 1 week of exposure. So I think I should conclude my talk. Hepatitis is the world's seventh leading cause of death, which is killing more people than HIV and AIDS, malaria, or tuberculosis. So how do we do this together? Eliminating hepatitis is very, very important because we will be able to avoid a lot of cases of cirrhosis and liver cancer. At least 85% of liver cancer cases all over the world today are just because of hepatitis B and hepatitis C. If we can eliminate hepatitis B and hepatitis C, we are obviously preventing this 85% of liver cancer cases. So improve awareness in general population about these viruses and their ill effects and the modes of transmission. This should be known to everybody. Driving awareness that these viruses are curable motivates people to get voluntarily tested to these viruses. I would suggest all of you to encourage voluntary testing for all your patients. When we identify positive patients and treat them, this decreases the burden of the disease and the chances of spread. So, great challenge is only finding the missing millions who carry these viruses and don't even know that they are infected. This is how we will be able to identify missing millions by promoting voluntary testing. Talk to them, tell to them about these viruses and their ill effects, and everybody will come forward to get a hepatitis B and hepatitis C screening test. Together, we can eliminate viral hepatitis if we work together, and we can achieve the goal of viral hepatitis elimination by 2030. Thank you very much for patient listening, and I'm ready to take any questions if there are.
Thank you so much, sir, for this rich deliberation. I'm sure our audience got to know so many things in this discussion. Sir, I can see a few questions from our participating doctors with all the question connected across.
Yeah,
Okay. Which forms of viral hepatitis are self-limiting and which require active treatment?
hepatitis A and E, most of the time, 99% of the time, they are self-limiting. And hepatitis B and hepatitis C are the problematic viruses. So if someone has hepatitis C, definitely you have to do viral load. And once the viral load is detected, you have to treat them immediately. Hepatitis B is also a problematic virus. I think with the discussion what we happened, We need to treat at least 50% of patients who have hepatitis B, and we have to follow up 100% of patients who have hepatitis B and hepatitis C.
Okay.
So once in 6 months, liver function test should be done. Whenever there is abnormality in liver function test in hepatitis B patients, we may have to treat them.
Okay. Secondly, sir, in hepatitis B related patients with tenofovir is ursodeoxycholic acid, vitamin E, and saroglitazar have some role or not in liver fibrosis or OTPT high levels.
If we are talking about only hepatitis B infection causing all these things, except tenofovir, there is no other medication which has any role. Please don't add any tablets. It is the tenofovir which has its role and which is going to reverse everything in your patients. All other things doesn't have any role in exclusively hepatitis B problem patients. There can be combination in some people where they have hepatitis B and a fatty liver, so maybe in those patients there is some role, but exclusive hepatitis B there is no role for ursodeoxycholic acid, there is no role for saroglitazar or vitamin E.
Okay. How do you balance the clinical benefit of treating asymptomatic carriers against the cost and side effect profile of antivirals?
So already we have limited number of antivirals available for hepatitis B. So asymptomatic or people who doesn't require treatment, whose LFTs are normal, we should not be treating them at this point of time because we may lose the whatever potency you have for the antivirals which we have. Already we have limited antivirals, so we should not be treating them unnecessarily in hepatitis B. Hepatitis C is completely different. You treat any patient who has viral load, you treat them. But in hepatitis B, you have to select your patients and don't treat everybody, even if their LFTs are normal.
Okay. Is there any hope for an effective hepatitis C vaccine to reduce treatment need in the future?
So actually, because of the potent antivirals which are available, a lot of research was being done before for hepatitis C vaccine. I think everything has halted at this point of time because there is a potent treatment available for hepatitis C. I don't think there will be any vaccine for hepatitis C at this point of time. We
Okay.
have no vaccines for hepatitis B, like we have hepatitis A, and hepatitis E vaccine is also coming into market shortly, but hepatitis C not in near future.
Okay. Sir, when we should plan to give immunoglobulins in needle injury?
Sorry, ma, I didn't understand your question.
When we should plan to give immunoglobulins in needle injury?
Needle prick injury. So first and foremost thing, as I told, you need to assess the antibody titers, anti-hbs titers. Anti-hbs titers are more than 100, you don't give immunoglobulin. Anti-hbs titers more than 10, less than 100, you don't give, you just give one booster dose of vaccination. If anti-HPS titers of the patient who or the person who got needle pricked is less than 10, that is when we have to give immunoglobulin and give the 3 doses of hepatitis B vaccine.
Thank you so much, sir, for your expert opinion that you have shared. And I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable time and for being with us at our platform and sharing such valuable insights. With all your
Thank you.
permission, can I end the live here?
Thank you.
Okay, sir. Okay. Thank you so much.